We're live.
Welcome to the reincarnation of Unremarkable Labs. A number of people asked us if we could make Unremarkable Labs a podcast. So some of you are just listening to this. However, we are recording with Zoom and we will have the episodes up both in a YouTube format as well as a podcast format eventually. The YouTube format, as you can tell, has come first. The idea here is to have attending physicians go through how they think through labs. We clearly want ideas from listeners of labs that they have difficulty interpreting. Sometimes it'll just be a lecture. For example, you suspect fungal infection, what test do you get and why? Sometimes it'll be routine labs, you get liver tests back and you're trying to decipher those liver tests and want to understand how to go through the process and want to hear a hepatologist tell you his or her method for doing that. Today, we're recording on fluid balance profiles, since everybody knows that I'm obsessed with fluid balance profiles. And I actually am familiar with the cases because I've discussed them previously and they're very, very educational. I do have 3 residents with me from UAB. I'm going to let them introduce themselves, and their job is to make sure that my explanations are crystal clear and to ask all the questions that you might if you were actually sitting here with us while we're having the discussion. So Miles, why don't you go next?
All right, hi, my name is Miles Anderson. I am a second-year resident at UAB. Initially grew up in Nashville, Tennessee, enjoying my time here. Excited to learn a little bit more about some labs from Dr. Center.
Great. Yasmin?
Hi, I'm Yasmin. I'm originally from Texas and also a second-year resident at UAB, and super excited to learn about labs and fluids with Dr. Center.
And Natasha is really the brains behind all of this. Introduce yourself, Natasha.
Hi guys, my name is Natasha. I'm also a second year here at UAB. I'm originally from Memphis, Tennessee, but have now been in Birmingham for a decade, so I feel kind of old. My role throughout the show is going to be as your host, and I will be presenting the 2 cases to Dr. Center, Miles, and Yasmin today. So if you guys are ready, we could get started.
Let's go.
Okay. So for our first case today, we have a 40-year-old female who's presenting with multiple weeks of arthralgias, dry eyes, and dry mouth. And I'm going to get you guys started off with just a BMP.
So this is in many ways a very easy case, but for a lot of people a very difficult case. So what I'm going to do for the people who are just listening is I'm going to go through the labs a little bit slowly. The sodium is 138. The potassium is 3.1. The chloride is 118 with a bicarb of 12, and that leaves us with an anion gap of 8. The BUN is 18 with a creatinine of 0.9, and the glucose is normal at 74. So the question here is, we have significant hypokalemia, not enough to cause symptoms yet, but 3.1 is low, and so we'd like to understand that 3.1. We also have a bicarb of 12 with a normal anion gap, so this is not going through the workup of an anion gap acidosis. Rather, we need to decide, is this a metabolic acidosis or compensation for respiratory alkalosis? Now, in my experience, bicarbs between 17 and 21 might be either. So I have seen people who had chronic respiratory alkalosis for a variety of different reasons who got their bicarb down to around 17. I suspect some people have gotten a little bit lower, but to get it down to 12 just seems too much for compensation for respiratory alkalosis. But one suggestion ahead of time is it's always good to get a VBG just to confirm that you're really dealing with a normal gap acidosis. So let's assume this is a normal gap acidosis. And I think that that's a very reasonable assumption. And the VBG confirms that. So we actually have an albumin, which tells us that the anion gap should be around 12. And we have a VBG that shows metabolic acidosis with appropriate respiratory compensation. So the learning points are, is it a respiratory alkalosis or a metabolic acidosis? So now that we know that it's a normal gap acidosis, we have to think through, is it going to be a problem of losing bicarbonate or not being able to buffer the bicarbonate that we are making? So let's think of that first. So normal gap acidosis is either lower GI losses, and it could be large volume diarrhea. It could be, I've seen it with ileostomies that had increased output from ileostomies. It could be from people who have moderate diarrhea, but also have some underlying kidney disease. So that's the GI losses. We haven't been given any history of that, but you always have to ask about stools when you see a normal gap acidosis. Then we have to think about the buffering system. How do we buffer the acid we eat every day? So here are a few pearls. We eat, and this is most every diet, and I think it includes vegan diets and vegetarian diets and all kinds of diets. We have to buffer about 1 milliequivalent per kilogram per day. So I'm approximately an 80 kilogram man, so I'm going to have to be able to buffer 80 milliequivalents per day. How do we do that? We have two buffering systems. We have the titratable acids, that's phosphates, and we have the non-titratable acids, which is ammonia to ammonium. Phosphates really don't change very much. They're more dietary, and our body can't adjust that. What our body can adjust is how much ammonia you make. Ammonia, remember, is NH3, but we excrete ammonium, we excrete NH4+, and that gets rid of that acid that we took in. That's usually about half of the buffering. That's a rough number. So we're not getting too mathematical here, but we know that there's a sizable amount. And if for some reason we either don't make enough ammonium or we don't concentrate enough ammonium in the countercurrent mechanism, or we can't acidify our urine, any of those things will lead to a normal gap acidosis. So let's see if we can remember where ammonia is made and how it goes through the tubule. So you were taught this once, and I bet that the majority of you don't remember it, that ammonia is made from the conversion of glutamine to glutarate in the proximal tubule. So remember, you had to learn glutamine to glutarate one time, and the enzyme's called glutaminase. So ammonia comes into the proximal tubule, and the proximal tubule is a little bit acidic, so we immediately have ammonium. We have ammonium until we get to the ascending loop of Henle. At our favorite place, the sodium potassium 2-chloride cotransporter, which is actually slightly wrongly named. It's really the small cation 2-chloride cotransporter. And in addition to sodium and potassium being absorbed there, ammonium is absorbed there. And it turns out ammonium is completely absorbed there. So in the latter part of the ascending loop of Henle, we don't have any ammonia. The ammonium goes into the countercurrent. It's neutral, so it goes back to ammonia, and it forms part of the countercurrent mechanism. So in the medulla, we're going to have a lot of ammonia. In the cortex, we're going to have very little ammonia, just like everything else that's in that countercurrent mechanism. That's as much as you have to remember about the countercurrent mechanism. In the distal tubule, by passive movement, the ammonia goes into the distal tubule. The distal tubule, if it needs to get rid of ammonia, is acidic. The pH goes down, and it's a classic buffering system because its microequivalents of acid lead to milliequivalents of ammonium. So what could go wrong? So the first thing to go wrong is with significant chronic kidney disease, you just don't make enough ammonia. So when we see people who have stage 3B, stage 4, stage 5 chronic kidney disease who have a normal gap acidosis, their first problem is they're just not producing very much ammonia in the kidney. The second problem is, as the quick timeout for the garage. As chronic kidney disease progresses to 3B, 4, and 5, the countercurrent mechanism doesn't have as much dilution or as much concentration. You don't have to remember a whole lot about the countercurrent mechanism other than it's flow dependent. Flow increases as the number of nephrons decrease because each nephron has to carry more fluid, and that washes out part of the countercurrent mechanism. So we're producing less and we're concentrating it less. And that's probably why you see patients with stage 4 chronic kidney disease who develop a normal gap acidosis and are put on bicarbonate. Sometimes they're put on bicitra or Scholl solution, sodium citrate. And that's just to keep the bicarb above 22. So in chronic kidney disease, there are 3 reasons for that. Number 1 is improved nutrition. Number 2, it decreases bone problems. And number 3 is it actually slows progression of kidney disease to take care of that acidosis. So that's the acidosis of chronic kidney disease. The acidosis of the proximal tubular acidosis fits into both buckets. This is too low a bicarb for proximal RTA. We don't see a lot of proximal RTA. Occasionally, we'll see a proximal RTA, often with Fanconi's syndrome. And if the bicarb gets too high, then we put out an alkalotic urine. But as soon as it gets down to whatever that new threshold is, it'll have a normal looking urine. So let's forget about proximal RTA in this situation. Let's go back to distal RTA. Distal RTA is called type 1 because it was discovered first. If anybody ever asks you that on a test, it's not fair. They should just say distal RTA. The problem in distal RTA is we can't acidify the urine. If we can't acidify the urine, we can't get rid of acid because we can't convert ammonia to ammonium. Excreting ammonia just makes our urine smell funny. screening ammonia makes it smell funny and gets rid of acid. There are a variety of reasons why distal RTA occurs. The final type of RTA is the so-called type 4 RTA, and that's a hyperkalemic metabolic acidosis. And this is the fascinating thing that I was taught about 15 years ago. The reason that hyperkalemia causes an RTA is because potassium inhibits glutaminase. And so therefore we produce less ammonia. So if you fix the potassium, you no longer have that normal gap acidosis. Now, this is very, very important in internal medicine, especially in primary care, because we take care of very many diabetic patients who have get to stage 3A, 3B, and develop hyperkalemia. And they develop hyperkalemia because they lose cells in the juxtaglomerular apparatus, which is where renin is made. So they have low renin, low aldo, and because you have low renin, low aldo, you'll have high potassium. Very common situation. A lot of people are borderline, and as soon as we put them on a medication that further inhibits the conversion of renin to angiotensin 1 to angiotensin 2, such as an ACE inhibitor or an ARB, those patients are much more prone to hyperkalemia. And so that's why sometimes that's a rate limiting step in being able to treat people with diabetic nephropathy with the appropriate medicines, which are an ACE or an ARB. And so you just have to be aware that that's the problem. Well, this is not type 4 RTA. We'll ask it if the patient has diarrhea. And this could be diarrhea, not very likely. Could it be a distal RTA? Well, what would be the key finding of a distal RTA? Well, when we have this bicarb of 12, we should have a very low pH. If the pH is not low, if the pH is 6, 7, or 8, that means that we have a distal RTA. We're unable to acidify the urine, therefore we're unable to convert ammonia to ammonium, therefore we can't get rid of the acid. So one would bet that with the bicarb of 12, it's either severe diarrhea or going to be a distal RTA. That's just from experience. This is too low for proximal RTA. We know it's not hyperkalemic, and we know it's not chronic kidney disease. So I would think that we're going to be looking for that. And I know that distal RTA causes hypokalemia. Now, proximal RTA also causes hypokalemia, but that's sort of where we stand right now. So what's the most common reason that you'll find a distal RTA? What's the most common disease? So this is actually a question they ask on boards and in-service exams and stuff like that. So Yasmin and Miles, do either of you know by any chance? I'll give you a clue: dry eyes and dry mouth. What do dry eyes and dry mouth make you think of?
Like an autoimmune process?
Yeah, and do you remember the name of it? It's named after a Scandinavian person, I think.
Is it? It's not Sjogren's.
It is Sjogren's.
Okay.
It is Sjogren's, and Sjogren's is famous for causing hypokalemic metabolic acidosis, a type 4 RTA. And I've looked it up, and I don't really understand exactly why. Now, other rheumatological diseases can cause it. You can get it with lupus. You can get it with a variety of other things. Sickle cell disease can sometimes cause a type 4 RTA, but that's about it. So we now know that the patient was on naproxen and acetaminophen without benefit for her arthralgia and dry eyes. We're going to ask about diarrhea. We're going to get a urinalysis because if that pH is high, we know what we have. And with the dry eyes and dry mouth, we're going to test her out. Now, we see the pH of 7, so that fits the distal RTA. They also did a urine anion gap. So let's explain the idea of the urine anion gap. So we have three main cations in the urine and one main anion. Now, there are others that we're not measuring here. So we have urine sodium, urine potassium, and urine ammonium. Those are the cations. And urine chloride is the major anion. In general, the cations will be a little bit larger than the anions. If the urine sodium and the urine potassium are less than the urine chloride, we can imply, and this is not perfect, but we can imply that there must be significant amount of ammonium to give the cations the right stuff. So a negative urine anion gap, which is the urine sodium plus the urine potassium minus the urine chloride, a negative one is GI losses. And some people use the way to remember that as negative. And so that's sort of cute. You, instead of spelling negative with an A, you spell it with a U. And that reminds you that it's in the gut. That's not true in this patient. The urine sodium of 150, the urine potassium of 20 add up to 170, and the urine chloride is only 100. So it's unlikely there's very much ammonium there. That's totally consistent with it being a renal problem because we're not making ammonium. And we already said ammonium is the most important thing. So we're pretty sure that we're dealing with a distal RTA because the patient's not acidifying the urine and the patient's losing ammonium. And then we're going to bet at Sjogren's because we always bet at Sjogren's if it's a distal RTA, especially once we get the history of dry eyes and dry mouth. So Natasha, maybe you can reveal if we thought through it properly, and then Miles and Yasmin, and you can all ask me questions.
Yeah, I think that's great. I especially appreciated that you went through the type 4 RTAs. I think I've seen those most commonly in the hospital, especially with patients who come in on a lot of NSAIDs. But so Sjogren's disease is the most common cause of a type 1 or a distal RTA. And the urine pH, another clue, is it's usually greater than 6. And as Dr. Centaur said, you can calculate a urine anion gap, which is the sodium plus the potassium minus the chloride, and we expect that to be slightly positive due to the ammonia. And then if you have a negative anion gap, it's usually related to GI losses. So usually, I guess this is just a little tip, anytime I have a low bicarb in a VBG, like Dr. Centaur said, or sorry, in a BMP, my first step is to obtain a VBG. And before Dr. Centaur was my attending, I'm embarrassed to say, I sometimes just ignored the bicarb in the BMP. I would look at the sodium, and then I would look at the BUN creatinine and glucose, and I would kind of make sure there wasn't an anion gap, and then I would just kind of ignore the bicarb. And then we had a really interesting case where we were attributing someone's hypoxia to their heart failure, but we diuresed them and he remained hypoxic. And Dr. Centaur pointed out that this patient had a bicarb of 16 for a very long time, and we worked it up, gave him some bicarb, and his hypoxia got better. So ever since then, I've paid a lot more attention to the BMP.
So Yasmin, do you have any questions? Or if you don't have any questions, what points do you really want to remember from this conversation?
Yeah, I'm also with Natasha. I feel like I tend to ignore the chloride in the bicarb, especially the chloride, just because with hypoxia and everything, sometimes you have to, in diuresis, I'm actually on CCU now, and now we're kind of like measuring bicarb based on how much we've over diuresed or under diuresed. But I feel like with all patients, especially, I think Dr. Centauri brought up a good point with like underlying autoimmune diseases, and that could also cause different types of RTAs. So I feel like I sometimes can overlook RTAs. This is just like a perfect case to kind of outline the importance of these labs.
Yeah, they're not real common, but it is worthwhile knowing it. Miles, what are your thoughts?
Yeah, I was just trying to kind of envision a patient coming into the hospital for the first time with this history and thinking through it. And a lot of the time seeing the non-gap acidosis, our first thought would be GI losses. And knowing that for a lot of our patients, we can't get a great history. Sometimes that diagnosis seems to be made almost by just empirically treating by giving normal saline. If there's some unclarity, is there any harm to the patient that could be caused by that, or would it mess up your urine labs later on?
So normal saline, if they have a decreased bicarb, might make it worse. I'd rather use lactated ringers. That's if you're sure they're really volume contracted. But usually volume contraction causes a metabolic alkalosis rather than a metabolic acidosis. So it would be unusual to be in that situation where they really need a lot of volume. Now, I guess if it was diarrhea, what I would do if there's a low bicarb, and I think it's due to the diarrhea, and I send off the test, but I'm pretty sure that, and you don't see it a lot. You see it occasionally with C. diff with really large volume. You see it more in places that have cholera. But if you do see it, I wouldn't give them normal saline. I'd actually take a liter of D5NW and put 2 or 3 amps of bicarb in it and actually give them bicarb, because that's what they're missing. They're not missing chloride. They got plenty of chloride. And so I don't think it's a good idea to give them more chloride when bicarb is really what they need. Does that make sense?
It does. Accidental slip on normal saline instead of IV fluids, but
Yeah.
Thank you for the clarification too.
Well, I think it's it's important to remember that we really have 3 major options in most people who we think are volume down. We can give them saline, we can give them lactated ringers, or if it's this situation where we think it's GI losses, we can actually give them, we can make up our own sodium bicarbonate solution. Well, great.
I have one more learning point that I forgot to mention earlier.
Okay, great.
The increased potassium wasting in distal RTAs actually causes increased absorption of citrate, so it actually puts you at higher risk of kidney stones as well.
That's correct. The other thing is, and we'll probably do we'll do another case, but a case that you may see on a test is someone who comes in with quadriparesis and hypokalemia. And hypokalemia, quadriparesis, and a metabolic acidosis, again, that's going to be a distal RTA. And there are many cases reported of quadriparesis because over a period of time, they can get severely hypokalemic. Thanks, everyone, for listening to this first in our new wave of unRemarkable Labs.